Good evening, everybody, and welcome to tonight's Facebook Live session. My name's Sam Ciotkowski, and I'm the Sales and Marketing Manager for Urology and Continence Care today. I'd just like to start by thanking everyone for joining us today. We do really appreciate you giving up your evening to spend it with us. So tonight's session is titled Impact of Diabetes on Continence, and we are joined by Caroline Knott, who's a Queen's Nurse and Deputy Head of Specialist Clinical Services. Welcome, Caroline.
Thank you.
Tonight's session is supported by Essity. So a big thank you to Essity for their support on this one. We'll be posting some links and things in the comments section at the end of the session and throughout. So keep an eye out for those. Big thank you to them again. Certificates will be available at the end of the session. So keep an eye on in the comments, our website and in the slides. Do submit any questions throughout the session. I'll be back at the end for a live Q&A, so if you can submit all your questions, then just put them in the comment section. We'll get through as many as possible in the live Q&A. Finally, do bear with us if there are any technical issues. I'm sure there won't be, but we are filming this remotely, so do bear with us. We'll keep you updated in the comments again. So that's all from me. I'll now pass you over to Caroline.
Good evening, and thank you, Sam, for the introduction. Today, we're going to be talking about the impact of diabetes for continence care. So the learning objectives this evening are looking at an overview of diabetes, the impact of diabetes and continence, strategies for patients with diabetes in maintaining their continence, and the management of their incontinence. So first of all, we're going to look at the anatomy and physiology of diabetes. We all need glucose as it gives us energy. How we get the glucose is food goes through the stomach and the small intestine, and it is broken down from the carbohydrates in the food to glucose. That glucose then enters the bloodstream, and gastric hormones then promote insulin secretion in response to this increase in glucose. The pancreas produces insulin, but in type 1 diabetes, this doesn't always happen, and in type 2 diabetes, the body is resistant to its effects. Glucose is then unable to enter the body cells effectively, and the increase in glucose in the bloodstream can then damage our blood vessels. So diabetes occurs when the pancreas fails to produce enough or any insulin to move glucose into the cells in our body. This causes a buildup of sugars in the blood. 1 in 15 people in the United Kingdom have diabetes, including 1 million people who have type 2, but have not been diagnosed. Every 2 minutes, someone finds out that they have type 2 diabetes. It is thought that 13.6 million people are now at increased risk of type 2 diabetes in the UK. And you are at greater risk of type 2 diabetes if you have a close family member who also has diabetes. And research has consistently shown that for some people, combined lifestyle interventions, including diet, physical activity, and sustained weight loss, can be effective in reducing the risk of type 2 diabetes by about 50%. Diabetes type 1 is the form of diabetes mellitus that is most common in children, but can be diagnosed at any age. It's an autoimmune disease that permanently destroys beta cells in the pancreas, meaning that the body can no longer produce insulin. Insulin is the key that unlocks the insulin receptor in the cell, and the release of insulin is triggered by raised glucose levels. Insulin allows glucose to enter the cell through the glucose channel by facilitated diffusion, and the effect of this process stabilizes the glucose levels in the blood. So it's an autoimmune disease that permanently destroys beta cells in the pancreas, meaning that the body can no longer produce insulin. And this type of diabetes will require regular insulin injections to manage the symptoms. Type 2 diabetes occurs when insulin is not effectively given by the body, resulting in insulin resistance and leads to hyperglycemia. In advanced stages, this may lead to damage to the insulin-producing cells, leading to insulin deficiency, which requires insulin injections. The majority of people with diabetes have type 2, and 9 out of 10 people who have diabetes have this type of diabetes. And typically out of the 2 forms, this is the most poorly managed. So what are our risk factors? If you're aged 40 or over, you're at an increased risk of having type 2 diabetes. If you've got obesity, so patients that are overweight, particularly with the larger middle areas, are also more likely to have diabetes. There's an increased body fat and consistently high blood sugars. This can lead to an increased demand of insulin from the pancreas. However, the insulin signal is less powerful the more it is used. And over time, the body cells respond less and less to the insulin. The blood sugar levels remain high and the pancreas can become inflamed. Another risk factor is ethnicity. It's found more frequently in Hispanic, African American, and Asian and American groups compared with other ethnic groups. With genetics, you're 2 to 6 times more likely to get type 2 diabetes if you have a parent, sibling, or child with diabetes. And if you've ever had hypertension, again, this will increase your risk. So what are the symptoms of diabetes? Patients find that they might go to the toilet a lot, especially at night. They may become really thirsty. They feel more tired than usual. They may have extreme hunger. They lose weight without trying. They can have genital itching or thrush. Cuts and wounds take longer to heal, and they may have blurred vision. So diabetes and incontinence. It's thought that people with urinary incontinence becomes a progressive condition with diabetes, and individuals with diabetes have up to a 70% greater risk of developing urinary incontinence. So what can we do to identify these patients? The most important thing is assessment. So assessment should include a holistic assessment, looking at the patient's medical, surgical and obstetric history, also a review of their medication. We need to review what their fluid intake is like. How much are they drinking? What are they drinking? Are they drinking high volumes of fluid or low volume? If they're drinking high volume, that could again indicate that you've got diabetes, but if you're drinking more, you're going to pass urine more often. If you don't drink enough, you can also have very concentrated urine, which will irritate your bladder. Looking at the type of fluids you're drinking as well, things such as caffeine are a diuretic, and they can make you have increased urinary frequency. So it's really important to get a very good input and output diary from your patient. We can also review the urinary frequency. So how often is someone going to the toilet? Most people will void between 6 to 8 times in the day and once at night time. So again, getting a good bladder diary will give you an idea whether your patient has got any significant problems. You also need to review their bowel symptoms as well, because patients with constipation also can have urinary frequency and urgency. We'd also do a physical assessment. So this could include things such as urinalysis, and particularly for diabetes patients, you want to check their glucose and ketone levels. We would also do a bladder scan to check the residual urine after they've voided to see if there's any problems with raised residual. And we may also do a vaginal examination as well to pick up whether there's any prolapse or other anatomical abnormality. We must also, when we're assessing patients, talk about sexual function as well. And quite often that is a neglected area of assessment because people find that quite a taboo or difficult subject to discuss. So diabetes and incontinence, there are 4 possible ways that diabetes can contribute to incontinence. And we're going to discuss them in more detail in a minute. But these include nerve damage, obesity, compromised immunity, urinary tract infection, and medication. So nerve damage. Several muscles and nerves work together to enable urinary continence and effective control of emptying the bladder. So what happens is your bladder starts to fill up. It's like a balloon. So urine will trickle in from the kidneys and it will send a warning message to your brain when it's about half full, saying, Caroline, you need to think about going to the toilet soon. Your bladder's starting to fill up. But you're busy. You're in the middle of doing a presentation, so that's not possible. Your brain sends a message back down and goes, not now, Caroline, wait a little bit longer. Your bladder fills up a little bit more and gets quite full. We'll then send another message to your brain along the spinal cord, again to the nutrition centre, to say to you, Caroline, you really do need to think about finding a toilet now. When your brain works properly, it's able to send that message back down to your bladder to say, well, hang on a minute, I need to get to the toilet first. I need to get in the right position. And then you're able to empty your bladder properly. But what happens is that sometimes these pathways get damaged. So it could be that there's some damage in the brain, the spinal cord, or some other nerve problems as well. And it's known that long-term poorly controlled diabetes can actually cause nerve damage and neurogenic bladder. So when you're talking to your patients, it's really important, if they have got diabetes, that you inform them that they need to keep their sugar levels stable, so that this will help to reduce the risk of them having neurogenic problems. And when I've spoken to patients in the past, they've got more of awareness of being told that it's going to affect their eyes and their feet, but they're not always told that it can affect other parts of their body as well. So the symptoms of a neurogenic bladder could include frequency, or urine retention, or an overactive bladder. Now, the problem is with some of these symptoms is they can mask what's really happening. And you may think somebody's got a very overactive, twitchy bladder that's making them go to the toilet. And I've seen mistakes in the past where people have been given medication to calm that down. But actually, the reason why they're going to the toilet frequently and it's desperate to get there is actually their bladder's not emptying properly. So all they're doing is emptying out the top all the time. So I have seen mistakes where patients have been given medication to calm their bladder down, and that's actually then made that problem worse. So urgency as well, if you've got a twitchy bladder, that's going to make you want to go. But again, if you're full, it doesn't take much to tip you over the edge to make you want to go to the toilet much more quickly. And then overflow is just where your bladder's so full, it's just tipping out over the top there. And of course, if your bladder's not emptying properly, you're going to get up more times at night. And again, if you've got an overactive bladder, that will make you wake up more times at night as well. And also you can have a urinary tract infection, and that could be triggered partly because of your diabetes and the sugar levels are high. But again, if your bladder's not emptying properly, you get a stagnant pool of urine, which is just a nice row. And then you can get kidney problems as well. Again, damaged by the levels of glucose in the system. But also if your bladder's not emptying, that can cause back pressure to the kidneys, which can cause long-term damage as well. So your detrusor muscle is the smooth muscle of the bladder. You can have what we call detrusor underactivity. So the bladder is supposed to store urine produced by the kidneys, and it empties at convenient times throughout the day. But some patients with an underactive bladder, their bladder doesn't squeeze properly, so they don't empty. And then you get residual urines as well. They also might have a lack of sensation. They go really long times without going to the toilet. So you can find some patients literally holding all day and not passing urine properly. Moving on to obesity. So obesity can cause problems. Your pelvic floor muscles are like a pair of internal knickers, and they support everything. They support your bladder, your bowel, and the sexual organs as well. And if you've overweight, that weight will put consistent straining on that pelvic floor and stretch it, and then cause further strain and weakness. And then a weak pelvic floor muscle will contribute to you not being able to hold on with your bladder and bowel, because if it's saggy, if it's giving way, then you are more likely to leak. You haven't got that supporting mechanism, that trampoline to hold it up in place. And quite often what I used to say to my patients is, your pelvic floor, if it's in good condition, it's like a big chunky pair of Bridget. But if you're coughing and sneezing a lot, we've got a lot of weight there, you've got a risk with things such as pregnancy and childbirth, then that internal pair of knickers almost becomes like a thong, and it hasn't got that oomph to help you to hold on. And also we know, we've just spoken, that obesity increases the risk of diabetes as well. Research has also shown that obese people are up to 80 times more likely to develop type 2 diabetes than those with a BMI of less than 22. And having a high body mass index is one of the most common causes of incontinence. It's estimated that about 5-unit increase in body mass index is also associated with an incontinence prevalence risk of up to 50%. And this is partially due to the increased weight causing additional stress on the person's pelvic floor muscle, but also it increases the intra-abdominal muscle and intravesical pressure. So it suggests that obesity can cause extreme additional pressure. So excessive weight can also ultimately lead to chronic strain, stretching, and weakening of the nerves and muscles of the pelvic area. And this then causes them to become weakened more quickly than in a person with a lower BMI. So ways you can strengthen your pelvic floor. So the first one we would do is look at pelvic floor exercises. So pelvic floor exercises are really helpful, but actually it can be really tricky to teach. It's very easy to say to somebody if they want to get them to exercise their arms, you can actually see what's happening. You can check that they're moving it in the right way that you want them to do. But with your pelvic floor, it's so hidden away. It's how do you check it's right? And quite often patients will get it the wrong way. So initially you can try teaching people verbally, but it doesn't always work. And we'll come on to how we would do that later. So quite often how we would teach patients how to identify their pelvic floor is by teaching them the anatomy that obviously is supporting the bladder, in ladies, the uterus, and then the bowel. And what you try and get them to do is identify a way of them to try and tighten up. I always say it's like tightening up that gusset of your pair of knickers without pulling in the extra abdominal muscles or your glutes. So we're trying to not pull those in. It'd be nice to have a nice tight bottom, but actually that's not what we're aiming for in this situation. So you can suggest to patients they can either try and stop themselves passing wind, imagining they're stopping themselves passing urine, but tell them not to stop themselves midstream because that can increase the risk of them having problems with their bladder. So imagining it. And some patients you can either say they're trying to either pull a pearl up vaginally or they're trying to stop a tampon falling out. So what you try and get them to do is tighten up that muscle. So I sometimes used to call it a bit like zipping up your gusset, and you try and hold it. Now, you'll also find that some patients just can't identify that muscle, and they'll get their breathing, and what they'll do is they'll take a big deep breath and then try and pull it up. And that's not what we're trying to aim to do. So patients need to be taught that actually you should still breathe normally while you're doing your pelvic floor exercises, and you should be able to breathe in and out and still hold up. The exercises as well, the muscles are made up of short fibers and long fibers, and you want to exercise them differently. So we teach patients quite often to hold up and try and see if they can hold for a couple of seconds, and then they relax for a couple of seconds. And if they can do that, then try and hold for 3 seconds and then relax for 3 seconds. It's very individual to what you want to teach a patient how to do their pelvic floor exercise regime. So get them to hold for as long as they can and then relax, but try and repeat it. And we do sometimes suggest about 10 times for that. But again, not all patients can do that. So you need to set it very individually for the patient. The other one you want to do is get the pelvic floor to respond quickly. So we also do quick exercises. So that's basically just tighten up, let go, tighten up, let go. And again, if you can do 10, that's great. But if you can't do that many, then build it up. And the suggestion is 2 to 3 times a day. But again, it's very difficult for patients to maintain that. So some of the things that we would do is we've got apps that can remind patients to do their pelvic floor exercises as well. If the patient can't identify it, then actually they would benefit from a physical examination. So we can actually make sure they're exercising their muscles correctly. And that's where qualified nurses or physiotherapists who can offer particularly individual assessments can be really helpful. And then they can examine the patient and tell the patient whether they're doing their exercises correctly. There are also devices that can be used. So they can be used internally. You can have ones with indicators that either go up or down. They help to tell the patient, if it's going down, it's fine, you're doing your exercises correctly. If it's going up, you're actually pushing your muscles down and you're going to make things worse. And then there are also stim devices where this can electrically make the pelvic floor contract. And for some patients, sometimes that's all they need. And they go, light bulb. I now realise how that's supposed to feel when I do my exercises. But your pelvic floor is like any muscle. If you don't use it, you're going to lose it. So doing it regularly really helps. But again, if patients are struggling or they get pain, they can't feel anything, they really need to be seen by a specialist nurse or physiotherapist. Moving on then, compromised immunity and your urinary tract infection. So diabetes and long-term elevated high blood glucose can contribute to urinary tract infections in several ways. If your sugar levels are high, then you'll have high sugar levels in your urine, and that just encourages bacteria to grow. And also, if your bladder's not emptying because of neuropathy, again, you're going to have that stagnant pool of urine that's going to sit there, and infections are quite common. So urinary tract infection, it's the combination of the immune system changes and the poor bladder emptying that causes these infections, and often they can reoccur as well. So treatment does include antibiotics, but also strategies to promote bladder emptying. So making sure patients are emptying on a regular basis. So you can teach them non-straining bladder emptying techniques, making sure patients are washing correctly. You know, they're not using too many soaps or hot baths that can aggravate them as well. You know, there is some school of thought, but it's not been proven that cranberry juice can help. But really, do you want somebody with diabetes drinking high volumes of cranberry that's high in sugar? And actually, there's also a risk if patients are taking things such as warfarin that can interact. Also, the reduced blood circulation reduces the ability of white blood cells to be delivered in sufficient numbers to help fight off infections. And high blood glucose and elevated urinary glucose levels also reduces something called phagocytosis. It's the process that leukocytes use to ingest bacteria, and you will then identify leukocytes in urinalysis. So we mentioned urinalysis earlier on, or dipstick in the urine. So what we would be looking for is like nitrites and leukocytes. So nitrites can be found when nitrate is converted to nitrites, such as in E. coli infections. But leukocytes are white blood cells. Now, the problem is with leukocytes, if particularly with ladies, if there's any vaginal discharge, you can pick up leukocytes from that. So when you're testing somebody's urine, you need to make sure that actually it's a clean sample of urine. So patients, they need to wash down below, again, not using any soaps or anything. And a midstream sample is better. So obviously they pee, stop for a second, and then pee. You're more likely to get an accurate assessment from that as well. Also, be careful of what they've put it in the container, because I've had some dodgy containers in the years, and if it's obviously contaminated, that might give you an inaccurate result as well. Also, if you've tested it for nitrites and leukocytes and you think there's a urine infection there, you may well want to send a midstream sample off to the laboratory for culture, so you can then identify which antibiotic may be the most appropriate one to prescribe. But it's not just the urinalysis that's important, because actually it's what the patient's symptoms are. So that's what we need to be looking at as well. So I mentioned the testing for the urine infection and the culture. So you also need to base the diagnosis on the urine test result as well as the clinical signs. So if there's no infection, there's no need for a treatment for urinary tract infection. But you might want to assess them and see what else is going on, and you might want to investigate, is anything else happening with them that's causing them symptoms similar to a urinary tract infection. But for a lower urinary tract infection, quite often you will need some antibiotics, and an upper urinary tract infection, so where it's affecting the kidneys, treatment is required. But what we're trying to do is avoid overuse of antibiotics, so then you'll get your multi-resistant bugs. So that's why we're trying to make sure that we are targeting urinary tract infection treatment appropriately. And then you've got asymptomatic bacteria. You're not going to give them any antibiotic treatment. So a full diagnosis should either be made by a doctor or perhaps a nurse prescriber who's able to prescribe antibiotics, but they need to take all these things into consideration before treating the urine infection. If you have got a urine infection, then, or the patient has, what we're trying to do is trying to make them feel more comfortable. So pain relief, things such as paracetamol should be enough to take some of that pain off. But what also can help is increasing their fluid intake, so you're flushing the bacteria out of the bladder. But also, if you've got more dilute urine, that's less likely to irritate the bladder as well. And a heating pad placed on the lower back or stomach may relieve the pain. But I've seen patients before that have used hot water bottles long term and then had scarring from that as well. So please tell the patients to be very, very careful if they're using any heated pads. So moving on to medication. So medication in diabetes can cause diarrhea. Most common one is metformin. I have seen patients as well that have been on diabetes medication with diarrhea, and actually nothing much has happened to them. But just saying to the GP, you know, could we try a slow release version of this? Sometimes has made a significant difference to their bowel habit. So if patients are having problems, they should really speak to their doctor to get some advice. But sometimes some things such as soluble fibres can help to firm up the diarrhoea and slow down the bowel motions. And sources of soluble fibre in diets are things such as oats, barley, rye, peeled fruit and vegetables. So moving on to continence care objectives. So the first one we're going to do is maintain continence. If somebody has already got their continence control, what we want to do is promote that and encourage them. So that would include things such as talking to them about doing their pelvic floor exercises, making sure that their fluid intake is adequate, that they're taking regular exercises, and that they've got good toilet habits. You know, they're not going to the toilet too frequently as a just in case, because that can increase the risk of overactive bladder or urgency. And again, they're not holding on to their bladder for too long and only passing urine, say, a couple of times a day. So it's trying to give patients some realistic goals that can help them to maintain their continence. If patients show signs of incontinence as well, we need to assess them. We need to find out what is that specific thing that's causing the problem. And it's not normally one thing that will fix a continence issue for a patient. It's usually a combination. So we need to promote the continence. We need to prevent further incontinence as well. So again, the things we've already mentioned before, making sure that they're drinking the right volume of fluids, it's the right type, they've got the right toileting regimes, you know, and things like pelvic floor exercises as well. Also, if the person has got poor mobility, is there something that we can do to support them? So things such as urinals and commodes being accessible may help them with that. And then managing incontinence. So there are situations where perhaps there's just too much nerve damage, you know, and you can't do anything to change it. So that might be some things that we might look at other ways of managing their incontinence. So for men, it might be things such as sheaths, or we might have to look at continence products as well. But they're the last resort. So when we're trying to choose a continence product, we need to consider what is going to be the most appropriate thing for them. So what product? So I'm not suggesting any particular product here because there are loads that are around, but let's just think about the different styles and things first of all. So the style, you could have a product that sits inside the underwear, and that might be sufficient for patients. And quite a lot of them have some lower absorbencies or some bigger absorbencies that can fit in there. You've also got the option of reusables, the all-in-one slips, belted products and pants. And what we have to consider when we're using these products is what's the fall risk. If we've got to take if we've got to take all the clothing off to change a product, that's not going to be suitable for someone who's got falls issues. We have to consider what's their dexterity like. Can they manage to put the product in properly? And what's the availability of the carers? When we're using continence products, what we're aiming to do is just try and catch the incontinence that the patient has in between going to the toilet. It doesn't actually replace them going to the toilet. So we still need to take those patients out to the toilet so they can still have some dignity and pass urine or have their bowels open on the toilet. But again, that's good because it's getting them up, it's getting them mobilized, it's getting their muscles working, it's getting pressure off their bottom as well. Then what also we need to consider is the size of the products. If you are wearing a slip product or a fitted product, we need to make sure it is the right size. If it's too small, it's going to be uncomfortable. If it's too big, it's going to leak or it's going to fall down. So we need to make sure we measure the patients appropriately. When we're looking at the products as well, we need to look at the absorption level. If somebody is only drinking 600 mils in a day, they do not need a product that absorbs over 1 litre and 4 of them a day. So looking at somebody's fluid intake and how much leakage they have can help you calculate the right size of absorbency of the products they need in a day. And what we don't want to be doing is wasting products. So, having a product that's changed too frequently. Most products will have some sort of wetness indicator that will give you an idea when a product should be changed. And it is known that some carers will take somebody to the toilet, and because they've taken them to the toilet, they change the product, but actually the product's not even half wet. So just think about that as well. Also, if somebody's living at home and they've only got carers going in twice a day, you're not going to give them 4 products because the carers are only there twice a day. So in that situation, you might provide higher absorbency products that can then be left so that it's just changed twice a day. And then fitting. We need to make sure that the products are correctly fitted. So most companies provide fitting guides fitting videos to help carers know how to put the products on and off appropriately. And also, just to add to that, we also have to be careful that when patients have got skin integrity problems, that we're not using too many creams. We do know that some barrier creams can actually stop the products working. So in summary, individuals with diabetes have up to 70% greater risk of developing urinary incontinence. And we need to be aware of the 4 possible ways that diabetes can contribute to this. So that includes nerve damage, obesity, compromised immunity such as urinary tract infection, and medication. So our roles are to make sure we carry out an in-depth continence assessment and then implement effective continence care, such as maintaining, restoring, and managing their continence. Thank you.
Brilliant. Thank you, Caroline. That was really interesting. We've had loads of people watching, and we've had lots of questions come through. So we'll move on to them very shortly. I will just say, for more information on those 10 products that you saw in the image, and for education from Essity, you can email them on hcmarketing@essity.com. That will be put in the comments section as well, and on the slide, so you can follow that. Okay, so moving on to the question and answers. The first question is, should we screen for diabetes at first continence assessment?
Yes. Simple answer is yes. You know, when I used to see patients, we used to ask them to bring a urine sample to every appointment, or sorry, at least the first appointment, and then we could do a dip test on there as well. But again, it's those things when you've got like frequency and urgency and fatigue and things, you start thinking, well, maybe this person does have diabetes. So yes, I would suggest it is assessed every time.
Brilliant, thank you. Question 2, patients with diabetes have annual reviews. Does this include questioning regarding their incontinence?
No. So I've checked this. So what happens is they usually get a urinalysis. So that's one thing that will happen. I know that in the annual reviews, sexual health is discussed, which is a bit of taboo. So I'm not sure that actually happens all the time. But I don't think there is a specific question for incontinence at the annual reviews that maybe it should be added in.
Yeah, brilliant. Thank you. Question 3, what are signs and symptoms for patients with diabetes and new continence issues?
So signs and symptoms. So again, we've got the frequency, the nocturia, urgency, increased urine infections as well. Also, when patients have got hyperglycemia, hopefully if they've got a urinalysis, you would be able to dip it and see anyway. But again, they would have increased urgency, nocturia, and frequency.
Thank you. So the next question, is getting up in the night a sign of issues in diabetes, and does this increase the risk of falls?
Definitely. So if you're getting up more times at night, greater risk of falls. If you're not sleeping well as well, you're more likely to trip over. But nocturia isn't just a sign of diabetes. You can have nocturia for other reasons as well, such as I mentioned earlier on, overactive bladder, a bladder that's incompletely emptying, or a urinary tract infection. So again, that's why you need that holistic assessment to actually identify what is the cause of this nocturia. And some patients get nocturia at night because they can't sleep. And they think if they get up to go for a pee, that they'll go back to sleep. So yeah, so you do need to do a thorough assessment to identify that.
Brilliant, thank you. Next question, do diabetic patients that are incontinent have more UTIs?
I would imagine, I can't say definitely yes, but I would imagine it is yes, because if patients have incontinence and they wear continence products, that can sometimes increase their risk of urine infections, particularly if they're not removing the product correctly. So that's why I said it's really important to look at the fitting guides. So I've known patients who kind of get almost lazy with their products and they just pull it out from the front. So again, if anybody's, particularly ladies, if it's coming from the back, there's a risk that they can contaminate with fecal matter. But again, if patients have got diabetes, there's a greater risk that they've got higher glucose level in their urine, which we spoke about earlier on, will encourage bacteria to grow.
Yeah, absolutely. Next question, if a patient has neurogenetic bladder, can they still exercise their pelvic floor muscle?
Depends if they've got the sensation. So it depends where that nerve damage is. So I'd say that would be individual assessment. And I'm probably not the best one. I probably want one of my physio friends to help me out with that one, but they're not here, so I can't call a friend tonight. But I would imagine there would be some difficulties because the nerve pathways are at a similar place. So it'd be individual.
Okay, fantastic. Thank you. Which type of urinary incontinence is more prevalent?
If you're looking at the general population, it's got to be stress incontinence with women. And that's because of the issues with pregnancy, childbirth, menopause. So all of those things make the muscles weaker. And again, we were talking about the impact of obesity earlier on as well, and all those stretched muscles. So in my mind, stress incontinence is probably the higher one, but often it might be mixed. So you might get a bit of stress incontinence when they're coughing and sneezing and leaking, but also a little bit of urgency and frequency as well comes into that sometimes.
Okay, brilliant. Thank you. At what point should continence referral be done? And that one's from Harriet. Thank you.
So at what point should a continence referral be done?
Yes.
I think generally, as for example, our community nurses can quite often give really basic advice, pelvic floor exercises, fluid intake, making sure it's the right kind of thing that the patient's taking in. If that doesn't work, if the basic doesn't work, then refer them on to the continence team. That would be my advice, because then they can see, well, is there something else going on there? I know our community nurses actually have bladder scanners. So again, they could do a bladder scan to make sure the patient is emptying their bladder properly. So it depends on what your resources are like as well. And if you're a community nurse in a very busy team at the moment, and I know things are pretty hard at the moment, you might not have that ability to be able to give as much support as you might have been able to do historically.
Great, thank you. Does type 1 or type 2 diabetes have a greater or lesser extent on incontinence issues? So which one has?
So type 1, when we looked at it earlier on, obviously patients get that at a younger date, so at a younger age. So hopefully they're going to be better maintained. But when we looked at it, the figures showed that type 2 diabetes is the one that's more poorly managed. And if you think about it, type 2 diabetes is usually brought on because of poor lifestyle, just poor lifestyle. So, you might be eating lots of things with sugary stuff and fats and things, and you're overweight as well. So actually to try and make those lifestyle changes and lose weight and stop eating so much sugar is more challenging. So I think that's probably one of the reasons why it's the type of diabetes that's less well controlled, and therefore more likely to cause the symptoms. Because again, if you're overweight, you're going to make your pelvic floor weaker, and then you've got the diabetes as well. So yeah.
Next question then. Is there a national guidance for diabetes and incontinence?
No, but there is one for neurogenic bladders, but I haven't seen anything specific for diabetes and incontinence. But NICE have got guidelines for urinary incontinence. They've got for lower urinary tract symptoms for men as well. So there are lots of NICE guidelines for incontinence, and those would be the ones I would be looking at, but not something specifically written for diabetes. But the tips or the advice would still be in there within the NICE guidelines.
Yeah, brilliant. Thank you. So on to the next question. Can some creams or soaps affect the skin and affect the pad effectiveness?
Yes, so you have to be really careful that the product you're using is water-based and it's not going to block the pores. So most continence products are made with like a pore that goes through, like a layer, and then taken through to the super absorbencies inside, and it traps it in. But if you put anything on top of that, like weave, it will block those pores and that urine can't go in, and it's just going to sit on the top and float. So not going to be good at all, and then that will lead to skin breakdown.
Fantastic, thank you. Next question. In your experience, are patients even aware they are at higher risk of incontinence issues if they have diabetes?
No. So when I've had patients come to see me in clinic, I quite often say, your blood sugar levels can affect your bladder and bowel function. Has anybody ever told you that? And people will say, no, they've told me that it will affect my eyes and it will affect my feet, and I've got to see the podiatrist, and I've got to watch how I cut my nails, and I've got to go for my screening for my eyes. And quite often they would say to me, but nobody told me it affect my bladder or bowels. And I think patients are quite upset about that. I did speak to a team who do teaching for diabetes and asked them, what do you talk about when you're doing the training? And I was told that patients are told that obviously diabetes can affect other parts of the body, but it's not specified that actually incontinence and the bladder and bowel function is one of them. And for those of us who have looked after people who've got continence problems, has a real impact on somebody's life, on their social life. So I think we should be increasing patients' awareness of that when they're first diagnosed.
Yeah, absolutely. So on to the next question. If they have overflow incontinence, are they more likely to have UTIs?
Definitely. So I spoke earlier on that a high residual urine, you're just tipping out the top maybe. It's just like a stagnant pool of urine. So what I used to say to patients, if you've ever had a bucket that's gone out in the garden and it's got filled up with rainwater and you see all that debris sitting at the bottom and it stagnates, that's basically what happens to the bladder that doesn't empty. So yes, definitely a higher risk of urinary tract infection there. But if bladder emptying techniques, we talk to people about tapping their bladder when they want to go, or peeing once, standing up and then trying to pee again, or slightly changing their position, then they may benefit for something called clean intermittent self-catheterization, so they can drain their bladder off. What we try to do is avoid indwelling catheters if we can, because indwelling catheters themselves are a really high risk of infection, and some patients can't tolerate them. And again, if you've got a bladder that's also a little bit twitchy, putting a catheter in can actually irritate that as well and cause the patient some discomfort. And they might even expel the catheter and then damage their bladder neck with a balloon. So yeah.
Yeah, brilliant. Thank you. Are there any key medications which can impact on incontinence that a diabetic person takes for their diabetes?
It's more the bowel and the diarrhea side of things. So such things such as the metformin. If you've got a poor pelvic floor, which we just said that some of our patients with diabetes will have because they've got obesity and they've not got their nice Bridget Jones pair of knickers and they can't hold on to something, and then you give them diarrhea because that's the side effect of their tablet, trying to hold on to something solid when your muscles aren't great is fine, but trying to hold on to something that's liquid, you just can't grip it. And then you're going to have a greater risk of accidents. And of course, having an accident is also going to increase your risk of a urinary tract infection as well. And if patients are in products, that increases their risk of skin breakdown as well. And one of the things I didn't mention earlier on with continence products is if somebody has had fecal incontinence on a product, you have to kind of change it there and then. You can't leave them in it. So in that situation, what we sometimes might do is give patients a lighter absorbency product if they've got a lot of diarrhea and we can't get it under control. So we're not wasting the absorbency of the higher absorbency products.
Brilliant, thank you. Next question, is diabetes-induced incontinence treatable rather than manageable?
It's treatable. So in most cases, it is treatable. There is a lot that you can do. And I think patients quite often assume once they've got incontinence, whatever the cause, diabetes obviously is one of them, that there's nothing that can be done, but there is. So if patient's bladder's not emptying properly, we just spoke about bladder emptying techniques and clean intermittent self-catheterization. If they've got an overactive bladder, sometimes adjusting their fluid intake might help. Sometimes we might medications such as antimuscarinic medication to calm their bladder down. But again, we don't want to go in that as a first choice because that has side effects as well. Toileting regimes, getting them to go to the toilet regularly, bladder training if they're going to the toilet too frequently, so practice holding on a little bit, and the pelvic floor exercises that we spoke about. So there's a lot that we can do, and it's not just go and stick a pad on it. So I used to say to people, sticking a pad on it is like sticking a plaster on a really nasty wound. It's not going to get better, it's just going to get worse, and the person's going to become more reliant on the product over time. So it's really do that really thorough assessment, find out what is going on, and then you can come up with your treatment schedules and different things that you can try and give to them as advice to try and make them better.
Fantastic, thank you. So on to the next question. This one, hold on. This is so. This isn't so much of a question. It's someone asking for some examples of some double voiding exercises for men.
Oh, so yes, there's a couple for men. So there's something called the anti-dribble technique as well. So with patients when they're not emptying, as I said to you, with women, we might get them to pee, then stand up and then pee again, or we might get them to tap, or we might get them to wriggle. Men, what happens is because the urethra has got a bend in it as well, sometimes we call something called the anti-dribble technique. So what you can do is press underneath in the perineal area, and that can sometimes help the genital empty out the last little bit. So what tends to happen is they think they've finished and they walk away and a little bit more comes out. But yeah, tapping's one. Yeah, I'm trying to think, can't think of any others at the moment. Those are the ones I can think of.
That's great, thank you. So I think on to our last and final question. Thanks so much for all your answers, and thank you everyone for all the questions. If we haven't got through to yours, we will try and answer those in the next few days, and we'll put those on our website. So it's the last question is, what impact has COVID had?
I kind of want to know in what context, because it's like that's huge.
Yes, I mean we could speak for hours on that. I think, couldn't we? But I mean, maybe just in your particular practice, how has it affected things?
I think it's just changed how we've delivered care. I think one of the biggest things is using technology. So I think 2 years ago, if you would have said like most assessments are going to be done online and they'll be using video links and we'll be able video training, we'd have gone, no, it's not going to happen. So I think that's one of the biggest things that has happened for COVID that's a real positive, is that we can now deliver care, I suppose in some respects quicker, so we can give patients advice. We're doing some places are doing like group education online as well. So I would say that's one thing. Initially with COVID, it was that delay because it took us a while to get into using the digital technology, and obviously things slowed down. We couldn't do the face-to-face. So some people I know are doing a lot of work assessing the patients virtually, and then only seeing those patients that need to be seen face-to-face for those physical assessments, in the clinic. So less work is actually happening in the clinic setting, but you still need to do that physical assessment. I know there are some areas that are using things like little educators for sending it out to patients to see whether they're exercising their muscles correctly. And I know some areas have thought about taking photographs and sharing photographs, but we are able to do hands-on care, although we're not doing as much as we were doing pre-pandemic.
Yeah, no, that's brilliant. And we have actually had one final small question through. Someone's just asked, how do you become a Queen's nurse?
Okay, so a Queen's nurse is a community nurse. So it's only available to community nurses. And what happens is you get nominated. So I was lucky enough to be nominated by a previous line manager of mine and one of my patients. And basically why you're nominated is because you're making a change in the community. So you have to show that you're trying to improve care. I've now been a Queen's nurse for about 8 years. And I will say it's a fantastic opportunity. So if you want to become a Queen's nurse, look it up online for the Queen's Nursing Institute. It is run by a charity. It's supported by the National Garden Scheme. So you do get to go to some nice gardens occasionally. But the charity actually sponsors a lot of events. So we've recently had a week of conferences with chief nursing officers being there, like really senior nursing staff. We had Michael Rosen who wrote we're going on a bear hunt, and we even had Prince Charles send us a message to say thank you for our work in the community during COVID. So it's a really good opportunity to find out what's going on nationally, but also you get links to link with other nurses nationally. So when you're saying, actually, I want to do this piece of research, I wonder if somebody else is doing it, then going through the QN, they will then share your details with somebody else to see if they can get you some help and support. So yeah, really, really good opportunity. So if you think you're up for being a Queen's nurse, definitely get yourself nominated.
Yeah, definitely. And that's a perfect way to finish the question and answers. So thank you again so much for your time tonight and for answering all those questions. I know there was a lot there. I'm sure there'll be lots more, but massive thank you from us and from all the people watching. So what I will now conclude today's session. We've got a couple of bits at the end. We've got a video first to show you, and this is a video. ST, they're excited to have launched a new continence care education path, and there's a wide range of modules on a variety of topics, from continence in acute care to end-of-life care and male incontinence. So they can support you with the implementation of that quality clinical care for your patients. So I will now pause for the video to play, and I'll finish off the session in a minute. So there we have it. That's everything finished for us here. So I will just run through a couple of final things. Thank you once again, Caroline. Thank you to ST for supporting the event as well. Thank you all for watching. The certificate link should now be in the comment section, so go there for your CPD certificate. The recording and the slides will all be on our website in the next 24 hours, so keep an eye on those. And if you want to watch back at any time, it'll be available on our website and on our Facebook page forever. Finally, just like our page so you don't miss any future events. We've got lots more planned over the next year or so, so keep an eye out for those. That's all from me. Thank you very much for joining us, and we'll see you next time. Cheers.